The Treuman Katz Center for Pediatric Bioethics at Children's Hospital in Seattle presents its second annual conference, Ethical Issues Related to Vaccination of Children. The Treuman Katz Center is the nation's first center dedicated solely to the study of research and healthcare for children. During this 5-part television series, national experts discuss vaccine policy, parental rights, and global controversies surrounding childhood vaccinations. In this program, Dr. Daniel Wickler, professor at Harvard School of Public Health, will discuss prioritizing vaccines for disease-endemic countries. The immunization policies of industrialized countries are not necessarily the best policies for developing countries. Dr. Wickler was the first staff ethicist for the World Health Organization. Dr. Douglas Diekema, Director of Education at the Treuman Katz Center for Pediatric Bioethics at Children's Hospital in Seattle, introduces Dr. Wickler.
Professor Wickler served as the first staff ethicist at the World Health Organization in Geneva. He's the co-founder and second president of the International Association of Bioethics. And his current fields of interest include ethical dimensions of health resource allocation, the ethics of experimentation with human subjects, and the ethical dilemmas of global health practices. And Dr. Wickler is going to be speaking to us this morning about prioritizing vaccines for disease-endemic countries. Immunization policies of industrialized countries are not necessarily the best policies for developing countries. Dr. Wickler?
Thank you, Doug. Great pleasure to be here, and it's a wonderful theme for a meeting, and congratulations to the people who put it together and the people who set up this institute. So it's a wonderful addition to the resources that we have in this country for looking at these kinds of questions. I'm going to probably defeat some of your expectations. Well, we'll just see. For some reason, I find that in my old age now, I wind up denouncing my field a lot. And I think that's a good thing, but well, we'll see. So let me begin on a positive note. So, noble era for vaccines and for international public health. Back when I was a student, and probably when most of you were students, you knew that there was some, there's a World Health Organization, and later on there was this program called UNICEF and a couple of other things, and they were all doing probably good things, but you had no idea what. And did I give it more than a second's thought through the first 30 years of my life? I doubt it. But what I see now, certainly at Harvard, is that if there is a cause for the idealistic kids there, it is world health, it's global health, and health in the developing countries. Focused a few years ago almost exclusively on AIDS. But now it's matured, branched out. We have undergraduates, for example, who are working on term projects on things like trying to come up with a new way of delivering TB drugs that might shorten the course for the standard therapy dots. One of the students in an engineering course actually made something of a breakthrough, and they're all talking to each other about it. Then there's an activism group, and the activism group has been going around to the major universities that have patents on drugs that would have a bigger health impact in developing countries if they would waive their patent rights. And they say to the university, you're not a rapacious drug company. What are you doing insisting on your IP rights? And of course, that's not what the university wants to hear. The reason they got that patent was so they could get money off of those inventions. And now these kids are saying, be the good guy. But the wonderful thing is that that's how they spend their vacations instead of going surfing. And so it's inspiring to see that whereas in previous generations it was the civil rights movement or all the stuff going on in the 60s, I would say more than anything, at least unless I'm really missing the boat, it's global health. That's begun to catch. President Bush has this PEPFAR program, surprised everybody, I think. Who would have thought that that would be what he did? But it was a lot of money, and although it's not quite as much as we thought, it's still, it's the major contribution out there. And now look at young Bill Gates. The fact that he's actually quitting that day job of his and going into global public health full time soon is just fantastic, and it's a sign that this subject has him in its grip. Now, given how smart Bill Gates is, by all reports, it's not so much of a surprise to find out that one of the big factors that led to Gates deciding to put his money in this field first, and then later on jumping into it entirely, was the groundwork that had been done by a lot of people, some in this room and others known to many of us, who tried to lay out with as much precision as possible where the problem was, what you could do about it, and to say if we had X number of dollars, we could relieve this much premature death and this much suffering from disease. And when Gates read this World Development Report of 1993, he said, he saw that all the homework had been done, and the argument was basically being made there, although not in so many words, that if you got a lot of money and you wanted to help humanity as much as you could with the money you have, this is the place to do it, which probably is true. And he responded to it, and now his friend from Omaha has responded to it. And so everybody's getting on the bandwagon. And the man who until a few weeks ago was president of Harvard, he did too, and he announced that he wanted global health to be a major theme of the entire university, not just the public health school, but throughout the undergraduate part of campus, the business school, everywhere. So it is a cause of our age, and a good thing too. Another thing that's wonderful about it, and this is, I realize I'm not sounding very negative. Another thing that's wonderful about it is what a unifying theme it is. It isn't us versus them. I mean, there are some thems, and we know who they are, but by and large, in terms of the big population groups, Bush is a very political man, and presumably when he pledged $15 billion for PEPFAR, he thought that his base was going to respond to it, and they do. And you can actually call on people from the evangelical activist group and also liberals and ask them to come to the same meeting and get behind some of the same initiatives in global public health, and they'll come and they'll throw themselves into it. And it's just wonderful. There's not another thing they can say to each other that pleases both sides. But on this one, everyone agrees. Maybe it's because the enemies are bugs, But be that as it may, don't knock it. So it's the religious and the secular, and then also it's the young people and us old people. So if you designed a cause that you'd like to come along, this would be sort of a designer cause, but it happens that it's extremely important. So that's just great. Now let's talk about the ethics, because I'm a professor of ethics, and I'm certainly not a professor of vaccine science. So, I don't want to give any impression along those lines in case I was doing that. So I'm actually going to talk about ethics almost exclusively for the next few minutes. But let's talk about what the role of ethics in all this sort of is. Well, everybody knows that whatever we do in this field should be ethical. So that's certainly true. But it's not actually that easy sometimes to figure out what that actually amounts to. The goal is so noble because the suffering is so pervasive and it's so awful. And the people who are involved in this stuff, in my experience, are the finest people I've ever known, both at WHO and at the Harvard School of Public Health. The professors, and I'm happy to say the students that I'm surrounded by, are paragons of humanity. Not all of them, but an amazing number are just paragons of humanity. They're both intelligent, and They have all the right motives and goals, and it's a great privilege to be among them. So that's great, but despite the nobility of it all, despite how wonderful the people involved often are, there's an ethical can of worms there. And when you get involved in this stuff and start framing policy, you see that choices have to be made that are very unsettling. Now, one nice thing about being a philosopher, which is what I am by training, is that I never actually have to make any decisions. So I'm not responsible for anything. I don't know if I could sleep at night. Even if I was doing a lot of good, the thought of having to make those decisions really freaks me out. So I get called in occasionally, as a consult. That's about as much responsibility as I want. So it's when you get in there and you see what a can of worms there is. And I could fill up the whole next 2 days just with these stories about all the worms that I saw at WHO. And it's not because the people are bad. It's because they're good. Because they're trying to do something in this area, and it's almost impossible not to take a false step. The reality presents you with these very difficult choices every damn day. I can't resist telling one story, not on the slides. Okay, this was early in my tenure there, and no one quite knew what a staff ethicist was. And I had big problems with the management office because there were a certain number of professional labels that they had. And you can't add one without sort of an act of God. And when they decided to hire an ethicist, they had sent an order down there that I was to have on my payroll thing, ethicist. And it's very hard to talk to these people. And what that reflected was no one had any idea what this actually meant. But it turned out that almost everybody in the building had been keeping a little list of ethical dilemmas that they faced. And when they heard that there was an ethicist in the house, the phones never stopped ringing. So I found out right quick what it was about. All right, so one of the first ones was vaccine safety. And this was excruciating. Here's the problem in just a nutshell. Turned out, sad to say, that a WHO vaccination campaign in Egypt had been a disaster. The locals had been reusing needles, and they'd spread, I forget which brand of hepatitis, but they'd spread hepatitis all over the place, and they caused much more disease than they prevented. So with that experience under their belt, they knew that you had to have a safe, you had to prevent that from happening. So the first thing is you get the needles that you'd have to be an engineer to reuse. Well, it turns out that in India, they have a lot of engineers because they were figuring out how to do it. So the question is, how often are they doing it? Because you know it's going to happen. And you almost certainly know that some people will be infected with HIV because of your vaccination campaign. Terrible. But, if you can't stand that heat, then you shouldn't be in the kitchen. So, all right, you accept a certain rate, but you don't want it to be like it was in Egypt, where you're actually causing more disease than you're preventing. So you have to have a good estimate. How often are they actually reusing those needles? Now here comes the crunch. The only way to get the estimate is you send out an observer. And the observer goes in and, of course, doesn't say why they're visiting the clinic. They just say, I'm coming here to admire your clinic. And you just sit there and you wait until they reuse a needle. Question is, just before it goes in the old arm, do you stop it? You can see the dilemma coming. If you don't stop it, you have just sat there and maybe watched someone get a death sentence. And you're a WHO representative. But if you do stop it, you don't have your data. You can't get an estimate. So there's no point in your being there. So what should they do? That's what they said to me. And so things like that happen, I would say, once or twice a day. And each one was different. But you can see how excruciatingly difficult this is. Whatever they said, something terrible was going to happen. Okay, so it should be vaccine policy. Any global public health, of course, should be ethical. Now, in a way, there's an easy way to be ethical. I mean, a lot of people don't do it, but it is easy, and that is to be above board, honest, not to be on the take, not to be taking money from a tobacco company or something like that. And happily, I can say in public health, the vast majority, the people I know about, are above board in that way. That's good. So you can be a good guy, you can be free of suspicion, someone could say, that they know you're a good character, and that's fine. What you can't avoid, though, are making choices in dilemmas that lead to disaster, because the reason they're a dilemma, the reason they're excruciating is that no matter what you do, something terrible is going to happen. Now, one of the problems, this is now where I'm going to start saying nasty things about ethics. One thing that happens is that very, very well-intentioned, wonderful people get it in their heads that to be ethical is to do X or Y. And with that comes a conviction that anyone who doesn't agree with you probably isn't all that good a person. Or at least if they're a good person, they're completely misguided. And you now have your compass set. And so you keep doing it until finally you realize what you've done. And it's been really terrible. Now, we probably all do this sometimes. But it wasn't until I got into this field, especially WHO, that I realized the magnitude of the disasters that happen when people take a wrong step, when they do this in a way that's not thoroughly thought through. There's a silver lining here for me personally, because I sometimes wondered, is there really any point to all this obsessive attention to arguments and logic and all this stuff we do as philosophers and ethicists? Or is this just a parlor game? No, there really is a point, I found, because there's sometimes when people just sort of take a little formula that they've learned. It's not necessarily a religious formula, it could be a secular one, but they have a good sense of what's right and they don't think about it very hard. And that's what leads to these wrongs. I'm going to bring up an example of this in just a sec, so it's not just a diatribe. But you could just say these are errors in ethical reasoning. Now, it sounds a little arbitrary to say, or sort of arrogant maybe, just to say errors in ethical. Who says it's an error? You mean you just don't agree with it? No, I don't mean that. I mean that even the people who are now making these errors, we can think that in a few years, some of them are going to look back and say, if I'd only thought about it more carefully, I wouldn't have done that. So sometimes we can give up even ideas that we hold close to the heart and that we think sort of define what's right and what's wrong. Now here's my candidate that I want to give you, and I hope I don't offend you by saying this, but it's the idea that above all we should have no double standards. And it's something one encounters a lot, both from people, again, high-minded, good people. They say, we don't want any double standards. And the people who think, and by that what they mean is that when you go to a country that's a developing country where the people have no power and no money and they're weakened from disease, so you're just much more fortunate than they are, you should consider yourself their equal at best, and they deserve everything that you deserve. There's no excuse for acting toward them or trying to help them in a way that you wouldn't do for someone here. Now, there are people who are dedicated to this who are among the most admirable people on the planet. Most of you probably know the name Paul Farmer and Jim Kim, maybe not quite as famous. They're both amazing people. They're doctors who have thrown themselves into the cause of trying to help the sickest of the poorest, of the most vulnerable in the world. Paul has dedicated himself to creating a clinic, not just a clinic to deal with AIDS in a rural village in Haiti, but to do it at a level of clinical excellence that's pretty much the same as what is done at Harvard. And of course, they said it couldn't be done, but he did it. And to hear him talk about it is extremely inspiring, fantastic. And because he does it, and because he spends half of his time down there, you can read all about this, by the way, in a book called Mountains Beyond Mountains. It's by one of his fans. Because he walks the walk, he's actually exposing himself to all kinds of risks and takes time away from, the nice environment we have at Harvard, so that he can be among these people he's trying to help. Because he is such a forceful example, we have some of the most talented and dedicated people, young doctors or medical school graduates in the country, flooding into his residency program. The number of people shot up, the standards shot up, and it's just the force of his example, because he really is dedicated to this proposition. As he says in his presentations, he'll show a picture of a girl, 16-year-old girl, and she's beautiful. She's from Haiti. She looks great. But a year before this picture was taken, she was at death's door, and it wasn't cost effective to treat her. If you wanted to be cost effective, you'd probably just let her die. But he said, look at her face. Are you going to say, I'm sorry, but you're Haitian, so I'm not going to help you? So he did help her, and now she looks like she's of infinite value. You think, he has to be right. Is he? Well, I have other colleagues there who, when they hear this, they tear their hair out. Because what they say is, and this is not done in public forums, but when the door is closed, what they say is that it's great for the handful of people he's able to treat, and the others, you could have helped a lot more others, and in the aggregate gotten a lot more health out of this, and many more people would have been helped if you hadn't lavished so much attention on the people that he has chosen to help. And in Haiti, in a place like Haiti or in Zimbabwe or whatever, you can't just assume that if you build a model program that everyone else will imitate you, because the money is not there and it's not going to get there. And so Paul and Jim Kim, who just came back from WHO, where he led this titanic struggle to get 3 million people onto antiretroviral treatment by 2005, got us about a third of that. What they've shown is that if you go first class, if you try to treat people in the developing countries as an equal, and you imagine that it was your own sister that you were helping, not just a foreigner or somebody who is, in one of those pictures we see of distant lands and looks like a native, but instead someone that maybe you care about personally. If you do this, this gets people going, and donors give money, and governments allocate money. And when they started doing this, the idea that you would try to actually treat people who had HIV, who had developed AIDS in the poorest countries, that was dismissed out of hand, partly because the drug prices were so high, but largely because it's a very complicated thing to do this, and it's just contrary to everything that we teach in our classes about how to be cost effective in international health work. But now it's conventional wisdom. Of course we do that. And you have political leaders in Europe who are saying that we should make sure that everybody who needs it gets antiretrovirals. And so it's no longer, I mean, if you stood up and said this as a politician now, people would say, well, where have you been? Whereas back before it was kind of crazy. So that's how the debate goes. But there are two sides to it. And Paul and Jim, they never have to, aside from the attacks of their colleagues, the public, I think, by and large, thinks that they are absolutely golden. And they are, really. They're just fantastic people. And they maintain these principles that there are no double standards. You treat people over there as well as you treat the people over here, and so on. But actually, there are two sides of this. And the debate does go on. Sometimes it's very bitter, but it goes on sort of behind closed seminar doors. And you can't avoid them once you get in there. So it's really difficult. The first time I met the head of the Gates Foundation, not Bill, but the gentleman who was there until recently, we had a little bit of discussion about what we're doing at Harvard in this ethics program. And he turned to me and he said, I think that ethicists are a grave threat to world health. And he wasn't kidding. He was not kidding. Now, I knew what he meant. I think he was referring to an incident that some of you may know about. There was an attempt in Uganda to do a trial of an inexpensive course of AZT to see whether or not it would interrupt the transmission of the virus from mother to child during childbirth. Now, at that time, it was known that a long course of this drug had very good effects overall. I mean, it didn't prevent transmission completely, but most of the time it did. The problem with it was that it was cumbersome, so the health systems there might not have been up to it. But the main thing was they couldn't possibly put that many women on that long course. It was just not affordable. So they began to wonder, suppose that we tried a short course, very, very, very short. Probably it wouldn't be even nearly as good, but it might be affordable. And the fact that there was an excellent treatment in existence and had been proven to work was irrelevant to most of the people who lived there because they absolutely couldn't afford it. Their only hope was if you came up with something that was cheap. And that would be great even if it wasn't as good as what we already had. Now, the problem was that, of course, you can't just start using it unless you test it. And we have principles of ethics of research, and they're codified in things like the documents like the Declaration of Helsinki that the World Medical Association puts out. Now, basically, those documents are documents that I think historically were formulated in reaction to the revelations at Nuremberg of what those beastly Nazi doctors did. And so that's the context that the framers of those documents had in mind. And in Germany, as we all know, German medicine was at the very top of world medicine, had been for quite a while. And in Germany, a very small minority was sort of removed from German society, put into these horrible death camps. And these doctors just treated them as if they were less valuable than their lab rats. Now, and of course, they got almost no medical care. So the post-war guidelines and statements of principle and so on all said that just because you're in a medical experiment, it doesn't mean that you should get anything less than the best care that's possible to give you. Now, that was all done in this context in which, let's say, 98% of the people had the expectation that if they got sick, they would get the world's best care. And so they were saying, of that context, that you can't just take some people out of society and then treat them as if they don't have any rights anymore. But that clause has stayed in the Declaration of Helsinki. It's there right now. There was an attempt to revise it, and they asked a very able committee to come up with something different, which they did, and that was rejected, so they reaffirmed it. So some of my colleagues, people I admire intensely, by the way, in every way but this, when they heard about this trial, they went on the warpath. And they said, this is double standards. You could never do that trial in the United States. Now, they were trying it against placebo. So they were trying a drug that they thought, or a therapy that they thought was probably not going to be as good as the best one, A, and B, they were doing it against placebo because that's what you needed to do to convince that country to adopt it. You have to show that it's better than what they got them, which is nothing. And so they went on the warpath and made it very, very hairy for quite a while. It still is to some extent for the people who were doing what to me sounded like wonderful work. And they were doing it because they were quite convinced that there's something deeply wrong with a scientist from the United States or England or France or something who would go to Uganda and do an experiment that, if it were done back home, everybody would say was terribly unethical. It's unethical because we would provide first-class care here. So I don't know what you think about it, but the more I thought about it, the more I thought my colleagues they're just wrong. Now, does that mean that I think that double standards are a good idea? Well, in the end, This is a different talk, so I'm not going to tell you how I solved this problem, but, or I think I have. It turned out that there was a different standard that arguably could be fashioned as a single world standard. It just turned out that it was kind of like a template, and you plug in local stuff, and so it's effectively different standards. But it's sort of, you could say it's a single standard, but not much rests on the semantics. The thing is, you have to be prepared to do something there that would be unethical to do here because the realities are so different. And how to give into the fact that the situation is so different there without completely losing your moral compass, that's one of these dilemmas that's just really hard to do. So let me just pontificate for just a moment about the other two items here. Another thing that I think I found out at WHO was that sometimes the right thing to do was something that looked awful to the public, because you were doing it because you'd considered all the ramifications of the problem, and you realized that what looked superficially like, you know, the thing of unimpeachable integrity and honor would result in a lot of excess deaths, and deep down it really wasn't superior in any way. But there's no way in the world the public was going to understand that. And so this then drove a wedge between two goals. One is to devote yourself to thinking as hard and as carefully as you can about these ethical issues so that you try to do the right thing and you don't do the wrong thing because you hadn't thought about it enough. And on the other hand, we serve the public. And the idea that, you know, we don't want to set ourselves up as these high priests who know what's right and, you know, play games with the public because they're not sufficiently ethical or insightful or something. But there it was. I mean, that was the fact. And that was extremely uncomfortable. I didn't like that a bit. But I couldn't get around it. It was true. So, okay. And the last thing here is on this sort of list of general lessons that I learned, or thought I did, was that a lot of the ethical issues that are most excruciating were invisible to the public. They're invisible to half the people in the building, partly because you want to sort of put the lid on these things. I mean, take the vaccine safety thing. That's so difficult to, you know, either choice, whether you intervene and mess up your surveillance, or you don't intervene and then you just, you know, you watch someone get infected. It's terrible. But you don't want to go around giving speeches on, you know, the dilemma I had today, because then, you know, you can imagine what that would do to WHO's vaccination programs. So it wasn't that they wanted to hush things up, and it's not that they were afraid of looking bad themselves and losing some career momentum or something. It would undercut their program. They cared passionately about their program. And so they hid the fact that there were ethical dilemmas. And it was only when I got in the building and got the phone calls to come in, look, we have a little problem here. Then I saw, oh my God, you know, this is terrible. But before that, it just looked great. You know, everyone's, no problems. How many people can we help today? So, okay. So this is this remark, save us from those ethicists, that I got from the Gates Foundation. So now let's talk about the application of this don't have double standards business to vaccines. This is a story which I'll bet many of you know. Can I just see a show of hands? How many people know the story of the rotavirus vaccine? Great, okay. So you can probably tell me more than I can tell you about it. But I was actually at a meeting at WHO, I think it was in the year 2000, in which it was a meeting attended by either the head of the equivalent of the FDA or someone similar from a bunch of developing countries, in which rotavirus was a major killer of kids. And 1 out of 250 kids in India dies of rotavirus, of a diarrhea that's provoked by rotavirus. So it's a huge killer. So for those of you who aren't familiar with this story, there was a vaccine. The vaccine had been used on millions of kids in America. Rotavirus it kills a few dozen in America every year, but by and large, although kids get sick from rotavirus, and hospitalization is not that infrequent, almost nobody dies of it. But in those countries, in the poor countries, especially South Asia and Africa, they die by the tens of thousands. So the real enemy here in those countries was rotavirus. But Wyeth is a for-profit company, and as a company that's gotten involved in vaccines, they're very aware of the public sensitivities about vaccines, and the fact that now if your vaccine pretty clearly leads to a gory-looking health problem, it's going to be problematic in the market. And the Wyeth vaccine, it looks like, did cause this intussusception of the intestine, this malformation in the intestine. And I believe about 50, 60 kids showed up with that. Maybe one died. I may have the exact figures wrong, but something in that range. Now, in the United States, you could have a good debate about whether or not it made sense to yank it from the market, whether it was good for public health, good for the kids to yank it. We now have other rotavirus vaccines, but we didn't back then. But in Africa and South Asia, the risk that would come about from the vaccine was infinitesimal compared to the risk that the kids already faced from rotavirus. And so if you had to choose, if you were a parent and you had to choose between keeping your kids safe from that vaccine or keeping your kids safe from rotavirus, if you had any wits about you at all, of course you would have them take the vaccine. No question. Nevertheless, at this meeting, I watched one after the other, the heads of these drug regulatory agencies stand up and say that they can't go before the people of their country and say, well, in America they decided it wasn't safe enough for American kids, but I've approved it for use with our kids. And so they didn't approve it. So there's a single standard for you. It wasn't safe enough here, it's not safe enough there. And that makes a lot of sense until you think about the fact that tens of thousands of kids die every year of the disease that the vaccine would have prevented in most cases. So it was, to me, it was a pure case of ethics gone terribly wrong. It was in the name of ethics, in the name of single standards, and in the name of equality and the equal value of each person that they made these lethal decisions, I should say. And how many tens of thousands of kids have died since that day who would be alive and doing whatever they do now? It'd be interesting to calculate it. I assume that it's a very high number. So what it shows, the point of all this is that we want to, when we think through these ethical dilemmas like that one, it's not enough to just sort of surf along using your trusty little list of principles like everybody's of equal value, because in this case it's led to tens of thousands of excess deaths of kids. And surely we could do better. Now, a colleague pointed out that we could come up with a universal principle here if we just had thought about it. And her suggestion was the principle should be every child is entitled to the treatment that would give them the best likelihood of survival or the best ratio of protection to harm. So again, it's one of these template principles. In the United States, it might mean that they wouldn't get the vaccine, but in Bangladesh, it certainly would mean that they would. And you could say, no, we're treating every kid exactly the same because we have this one principle and we apply it to every single kid. It's just that the principle allows you to take note of local conditions, and when you do that, it turns out some kids would get the vaccine, others would not. But that's not how people were thinking. And so it was a situation where people actually said, it's because of ethics that I'm not going to allow this to be used in my country. So basically, the crunch here is this. When we talk about it, the context of world health, not American health, although there are pockets of, we have an archipelago of the third world running through this country too. When we talk about world health, there's one big brute fact, and that is that in a lot of the rest of the world, in the poorer parts, they're just vastly poorer and much, much sicker. And so the question is, what happens to your ethics in that context? Do you have to adjust things at all? Do you use the Farmer Kim approach and say, you know, that I'm not going to pay it any attention? Or do you say, no, things really have to be different here because we can't ignore these root grinding facts? So let me give just a few examples. I put up this provocative phrase, can the poorest countries afford our ethics? And I don't know, but maybe you can tell me. Let me just give you a few examples. Suppose that you develop a new vaccine, and your guess is that the vaccine is going to be most effective if you give it to the kids, and 3 months later you come back and you do a booster. And if you were introducing the United States, that's what you do. Now go to a very poor country. Should you think that way? You should if you're thinking, how can this vaccine help each kid the most? Each kid that's going to get it the most. But if you do that, there's some problems. One thing is, this is going to be the only trial. You're not going to get 5 passes. So if there's some chances to learn something important and you don't do them, who knows if it will ever be done. Now, sometimes these vaccines have long-term adverse events show up. And you have to think about that. And you don't want to trip things up and mask them in any way because of that. With a booster, if you give the booster to all the kids, there will not be any way to know whether or not the booster really was necessary or how important it was. The only way you would know is if there were a whole lot of kids who suddenly got the disease that they'd just been vaccinated for just before they got the booster. That's probably not going to happen. I guess it has happened sometime, but it's very rare. So if you just give them the booster, there's no way of looking at the data and saying, boy, good thing we gave them the booster. But if you don't give them the booster, you might find out that it really was necessary. But you also might find out it wasn't. Now, since every penny counts, that's very valuable information. So probably the best thing for your purposes as the Minister of Health or something in this very poor country is you deliberately withhold the booster, and then you sit back and you wait for some of these kids to get good and sick. And then then you know that in the future you should give the booster to other kids. So is that ethical public health, where you deliberately leave out sort of the second half of their medical course just to see how sick they'll get? Probably it will have an effect on some. The question is how many. If every penny counts and you just don't have any money, and either you do the maximum good you can do in this case with very little money, or else you're going to be taking from something else that's more urgent, then you omit the booster and you wait for the kids to get really good and sick. Okay, next one. You've done a randomized trial of a vaccine, and let's say it's kids again. Now, one would like to think that when the trial is over, you've reached the endpoints that you set out at the beginning, you've achieved statistical significance, so the trial is fini. And hey, it turns out it's very effective. Well, surely ethics tells you have to go back and vaccinate the kids who were in the control group, right? Who got placebo, right? How could it be ethically defensible not to do that? But if you do that, 2 bad things happen. One thing is you've lost your control group, and in a way the trial isn't over, because the trial's over. It turns out that, let's say it's a trial for pneumococcal diseases, which mainly kill off the kids in their infancy. And you've let this go on for 5 years now. So it's over. But older kids do get this sometimes, and sometimes it kills them. And so you want to know, how long does the protection last? And if you don't have a control group, you can't compare the 2 groups, and you just don't know. Whereas if you just don't vaccinate those kids, then you have a control group. And you can keep the data going, and you'll know whether or not this vaccine actually protects kids for a long time. So how about that? Or let's suppose that you want to know whether the kids who got the vaccine had some long-term adverse sequelae. You're not going to know unless there's a control group that didn't get it and it's otherwise matched, and then you can compare and see whether or not these weird things that happened to some of the kids also happened in the control group. Now, you only have one pass at it. You get to do this once. And you did this big, expensive trial, and you took people away from all these other important medical jobs that they had so they could do this one thing. And are you going to throw all that away and not learn all you can from this huge investment of your time and energy? Because if you'll just keep the controlled kids unvaccinated, you can keep learning, and it may have important public health consequences. Now, you can imagine if we did this here, what people would say. But we're not in situations in extremis the way they are. So can they afford our ethics? And what would you tell them to do? Here's one that's rather abstract, but I'll tell you about it anyway. When you do cost effectiveness analysis, which is essential for all this global health stuff, you're not just crunching numbers. It turns out the more you look at what goes on in the actual performance of cost effectiveness analysis, you realize how much of this is a series of ethical choices. Now, one of the ethical choices is this. Should you count the health of each person as an equally important goal? Rich and poor, let's say. If it turns out that some vaccine has a much stronger effect on the rich than it does on the poor, should you take any note of that? Or should you say, look, we just want to know how many lives saved, or how many life years, or how many disability-adjusted life years. We're not interested in how rich the people were, who they were, what race they were, anything like that. We just want to know how much health did we get. Well, WHO decided at one point that as a matter of principle, I mean, this is something quite admirable, as a matter of principle, they would ignore non-health outcomes. And they just wanted to know how much health you got. And that put everybody on the same standing. It could be the king, or it could be the lowest peasant. They counted just the same. Now, it turns out they got the productivity in through the back door another way, but they were very proud of the fact that they took it away out of the front door anyway. So, I mean, it's remarkable, really, because these were a bunch of hard-bitten economists, and here they were taking a stand on principle that they didn't want to do things the way it was usually done because they thought it was just wrong. Now, the problem is, though, that in the poorest countries, it turns out that one of the things holding them back from economic development is bad health. To a certain extent, when you put money into health, it's not just relieving suffering, it's actually making the economy expand. And they were holding themselves back. They were losing dollars, or whatever the currency was. They were losing money because they hadn't spent it on health. It would be like saying, well, we're not going to spend any money on oil. We want this economy to move ahead. Well, got to have oil, So the Director General of WHO, when I was there, Dr. Brundtland, commissioned a special group, the Commission on Macroeconomics and Health, to try to estimate what the economic effects of a certain investment in health were, and that's what they said, was that up to a certain point, investment in health actually pays for itself. Well, these are desperately poor places. Can they afford not to look at the economic effects of health interventions? In which case, what happens to the wealthier people would count for more. If you help somebody who helps to run a plant or is essential to the economy, then that makes him healthy or her healthy, but it also has all kinds of economic benefits, not only for that person, but for a lot of other people, which means that it's more important to help that person, and maybe you should put your resources toward helping that person rather than 3 other people who are poor. So here they took a principled stand, but was it in tune with the necessities, the realities of what's happening there? Now, when you become aware of the ways in which these ethical questions sort of begin to arise even in what looks like a dry statistical table, you see that it just doesn't stop. And this actually goes on for quite a while, but I'm just going to take this one more step. One of the ethical problems that had been totally invisible to me before I went there had to do with the question of whether or not we should discount future health benefits. And here's what this means. You're all aware of when you do some kind of projection of return on investment for a bunch of different possible investments that are open to you. You'll say, okay, well, this would produce so many dollars in 2015, and this other one here wouldn't pay off till 2025, and it would give that many dollars. And it's not okay just to take the number of dollars if they're going to be returned in different years, because a dollar if I said, look, let me borrow $10 now, and I'll pay it back in 25 years, and so you see me again in 25 years, and what I do is I just give you $10 back. And you say, wait a minute, come on, you probably invested it, so you're probably sitting on $20, let's have it. The point is that your $10 today is worth a lot more than the prospect of getting the same amount back 15 years from now. So what you do when you find out that you're going to get some dollars back in the future is you discount for each year so that you can compute the value to you in present day dollars. That's orthodox thinking. There's nothing wrong with that. Question is, do we do the same thing with health outcomes? Suppose that I could give you a vaccine today that would avert a death 30 years from now. Should we count that death as equally important as a death we could prevent tomorrow? And we have a real life dilemma right now about this. As I'm sure you all know, we now have a vaccine that will prevent the virus that leads to cervical cancer. And when you give that virus, you give it to, the plan now is to give it to girls before they start sexual activity. So you give it to 9-year-old, 11-year-old girls. Let's say that sometime between the age of 16 and 35, they acquire this virus. There's a long latency period. Then the tumor starts to grow, and if it's not found, which it probably won't be, it becomes a life-threatening event, and some of these people who have the tumor later on will die. There may be a 30, 40-year lag in time. But you have to give the virus now, and it's not free either. So what we want to know is, when we think about whether or not to give that virus, should we think, okay, well, the lives saved aren't going to come for quite a while. What's our present day value of those lives? I've convinced myself now that it's one. The time shouldn't matter. The standard thing to do in most of these studies is they do discount it about the same as they do dollars. So there's a big debate about this. All right, but that occurs in the United States. When you get to a developing country, though, maybe it looks a little bit different, because the person you save today could become productive. And money is what they need above all. Whereas if you save a life some years, decades away, that's not going to help you. So you just can't ignore the overwhelming fact of poverty. All the time, in every way, it puts a shadow and it colors every one of these decisions. And it's your job to make the most ethically defensible decisions you can and to decide whose value really is equal, or should you just say, look, maybe in the States that's so, but here they're not equal. We can't afford those ethics. So we could go on with this, as you can see, for quite a while, but we are out of time, so we're not going to. But the point of this, if you're wondering, is that just as we find that when we get into vaccine policy in the developing world, when we get in there close, we find out that what looks like this wonderful choir of angels, everybody doing good, they probably have no ethical dilemmas at all. When you get in there, you find it's a hellhole. You know, there's horrible, excruciating dilemmas, and everybody knows they're going to be doing something horribly wrong, even though they're doing good. The weird thing was, you know, I started seeing that. That was my first big revelation as the ethicist at WHO. And then I realized that I'm doing it too, and that all this ethical stuff is going to, you know, there are dilemmas for, you know, for how you work out the ethical stuff, and a lot of the outcomes are horrible too. You just couldn't get away from it. So it's a lot easier being ethical and being an ethicist in a rich country than it is when you get into these third world contexts. So that's a reason not to do that, but there are the compensations on the other side. Thank you.
You have been watching a session from the 2006 Pediatric Bioethics Conference, Ethical Issues Related to Vaccination of Children, presented by the Treuman Katz Center for Pediatric Bioethics at Children's Hospital in Seattle. For more information about immunizations, please visit the websites listed here or go to seattlechildrens.org/bioethics. The Childhood Immunization Schedule, www.cdc.gov. The Immunization Action Coalition, www.immunize.org. The Influenza homepage, www.cdc.gov/flu.